Hello, so I'm Faith Ramsey, and today I'm going to be talking about death with dignity, which is what I named my essay. I named my essay Death with Dignity because I do feel like that is what end of life care should be about. So, so this is my thesis statement. It states that end of life care can be a terrifying decision followed by feelings of guilt, and many more. End of life care is an option for those who qualify, and the benefits may outweigh the fright. I feel like this statement really gives an outlook on what end of life care is truly about, because end of life care is terrifying for both the patient and the family if they are involved. And it's really crucial to realize that the benefits that end of life care provides to these patients are always going to outweigh what someone else or the patient may be feeling about it. So, some important things to note before we just dive into it is that these circumstances can happen to anyone, including one of us or a family member. So, this goes for all ages. I know we don't like to think about it, but every age can get sick or be involved in a traumatic accident that leaves them with no other choice. This can happen to our children, our grandparents, ourselves, our brothers, sisters, anyone. So I think it's really important for everyone to be educated on this topic. So today in this presentation, I'm going to be going over the different types, the decisions, the ethics that surround the decisions, and each experience that may be a possibility with each different type. So the first type of end-of-life care that I'm going to be talking about is palliative care. So, palliative care consists of better quality of life while one is still alive. They have less than 6 months to live, but they can exceed this limitation. They won't be kicked out of their palliative care plan. It may just change if they exceed the 6 months. These are more so, like I said, a comfort measure for a person so they are not alone and do not have to make decisions on their own. So, this is kind of just advocacy and a part of your care team in the hospital and out of the hospital that are going to help promote the best quality of life for you. So now we're going to talk about hospice care, and I forgot to add this on the original palliative care slide. These pictures I specifically chose to kind of show what the situation looks like. So right here we have little old mama in bed, and that person in scrubs is most likely her hospice nurse. So now we're going to talk about what hospice care is. I would like to start out by saying that I have worked in hospice before, and I have had many hospice patients in the hospital setting. So when I speak about this specific one, I do have a lot of personal connection with it. So hospice is an in or outpatient type of care. They provide comfort measures such as pain medication, connection with family, or even spiritual technique. So this differs from palliative care because palliative care is more so, like I said, that advocacy, and just really helping you make decisions. When you come to hospice, you have made your decision. You are done fighting. Not even necessarily done fighting, you're just done pursuing your treatment. Whereas with palliative care, you can still continue your treatment with that. So, as a patient in hospice, you're really going to be focused on in the ways of pain control. If you haven't seen your family in 20 years, they will call that family member for you and try to get them there. If you have spiritual ways, they will meet those requirements for you in your dying process. I was going to put on here that hospice is typically utilized within 6 months of dying, but I will say from experience, usually if it's utilized in the 6 months before death, these patients are going to be at home with a hospice nurse at home. But usually, from what I've seen, if someone's in the hospital making this decision, I want to say about a month is the most I have ever seen out of tons and tons of patients of how long they have left to live. So now we have comfort care, and this is when you have less than 7 days to live. This is very fast. The death is very fast, although it says less than 7 days to live. Um, it's usually within a day or two, just depending on the patient. This is usually accessed while they're in the hospital, and it's the same concept of hospice, just much shorter. So, pain control, family at the bedside, everything is possible. Everything will be done to keep the patient comfortable. It's just a much smaller time frame. So, whenever you're making this decision, your care team is going to have physicians, nurse practitioners, nurses, and CNAs by your side. They will also be there to console the family. Your physicians and your nurse pracs are really going to be the main part of the team actually implying this decision. They're going to be the ones who suggest it, while your nurses and CNAs are going to be giving that physical care and maybe emotional support while you make the decision. And that goes for family as well. So, with family, I feel like it's most common, but even patients, the ethics surrounding are going to be your grief, your anger, and hope. And I really feel like it's important to understand this because when you find out someone is dying or yourself is dying, the grief is going to set in. The anger, there are multiple instances where the anger at the doctors because they can't do anything else, or just even maybe at a spiritual power, those can really set in. And hope, maybe your loved one had a stroke and you are really having a hard time grasping that they are just no longer in there. I added this quote from my essay. It says the first thing is to understand the process as someone is dying. And I completely agree with that because I feel like if you don't understand the process and you don't understand that they are truly dying and what that means, then you will not be able to make a good decision. So now we have each individual experience. So as we talked about with palliative care, this is just an example of a patient that I made up, of course, but the patient will continue life as is with help of their palliative care team. They can view them in office, they can seek them while in the hospital, and it's really just going to be patient centered, and the advocacy will be present from the palliative care team. Then we have a patient who was diagnosed with an embolic stroke, and they have chosen hospice. Their family has made that decision for them. So they will be made comfortable with pain medications, their vitals will be taken, and family will be at the bedside. They will also be educated on what to expect, and something they may educate on is the body becomes very cold during the late stages of death, so that can prepare them. And then we have a patient who's admitted into the surgical ICU and is extremely septic. They have no MPOA. MPS makes them comfort care because there are no signs of life, brain wise. So now we're to our conclusion, and the whole point of this presentation and my essay is to prove that this is extremely beneficial for someone who needs it. A lot of people decline this care, and it leads to pain and suffering for their loved one or for someone because they are uneducated on what this can really do for them. The decision should always be patient-centered and not based on someone or something else. And of course, this is available everywhere across the country for everyone who may need it. So thank you guys for listening to my presentation, and best of luck.